Oh, that's no way.
Test. Test 1. Test 1, test 2.
Hey, Justin, can you hear me? Testing.
Okay, everybody, if you'll turn your cell phones off. We're still waiting for a quorum, but I think and so if my committee members that are not here, if they give you too many questions and they miss this, you let me know and I'll tell them they have to read the bill before they can come ask you any more questions. We do have people online. And, part of this, as far is to let people that are interested, that are listening in or here in the audience also know about this substitute. And when the presenters get through, we will take comments from people in the audience and online. As long as we have time, we have to be out of this room at 2. If you have made comments before, then we're not going to let you make comments again. And because of time restraints. And we do have some copies of the new sub. We're waiting for members to come. I'll put out what we have left over when we get through. Because it's hot off the press. It was still warm, or they were still warm just a minute ago. Okay, so what we're going to do is I'm going to have Representative Oliver and Representative Jones present the bill. And the first will take questions from members of the committee and go from there. Okay, you have the floor.
Good afternoon, Madam Chair, Representative Chair Jones and I are happy to be here again with you. And I think this is a good opportunity for us to summarize for the committee all of the amendments that have come in. And I will go through the new sub, which is 339030S, and tell the committee members what we have inserted, what we have deleted, and highlight for the committee members some other ongoing issues that are under discussion. That are ongoing discussion issues are always very important, and we intend to move forward. We are very grateful for this opportunity. Everyone that has given testimony last week have been very generous with giving us specific suggestions. We have probably gotten anywhere from 40 to 60 new amendment suggestions. And it's been a good exercise to vet out the bill, and we will continue to do so. Our goals for the Georgia Mental Health Parity Act are to improve and coordinate in a much better and efficient way services for the mentally ill of Georgia. We have an opportunity in this bill with our primary goals of enforcing parity, enforcing the existing legal obligation that managed care organizations satisfy the federal mandate that they provide 85% of their premiums for direct medical care. And we are in several ways, as you know, as we've discussed before, coordinating and trying to strengthen and bolster the issue of crisis intervention in a variety of ways. Our conversations are ongoing, as I've said, with many different folks, and we are not done by any way. I think it might be helpful at this time for the folks that want to testify and continue to offer suggestions that I go through the bill and just tell the committee and the audience what changes we've made at this point and what we intend to further discuss. On the issue of parity, we have had a good many different discussions, again, about the definitional sections about what mental health services actually are. And we are staying mostly with the definitional sections that we originally came forward in last week's sub. We've accepted some new language beginning on page 7 around line 145 that's been offered by the managed care organizations. And we have also implemented on page 8 around 168 a very important amendment that we've heard a lot about, that no healthcare entity shall implement any prohibition for same-day reimbursement. That's something you, Chair Cooper, were particularly interested in we inserting into the bill. And I think that's a very good amendment that came forward from last week's discussion.
Mayor Morgan, just tell you that I did talk to Ryan Loke, and apparently he tells me that they have been able to do this several years now. It was corrected, but the word didn't get out. But he's sending me, I'm glad it's in the bill, but he is sending me clarification. So I will have that. If anybody's having problems with that later on, I will have a clarification of that for people.
That's very helpful. And again, it's an example of why the testimony of the hearing and coming forward has encouraged us to drill down on an issue that we want to solve, and we can solve it. It's just fine with me if we solve it in multiple ways. The other thing that we have inserted as an amendment, and this came from a variety of different speakers, and it's set forth in the bill in a variety of different ways, a reference that we have to figure out a way. Commissioners shall undertake reasonable efforts to make culturally and linguistically sensitive materials available. Specifically, if somebody has a complaint process, they need to be able, a complaint on enforcement of parity, they need to be in a position to be able to use the appeal process and communicate with the operation that's set under law for us to appeal violations of parity and understand how they're going in a variety of different ways. As we know, 10% of Georgians were not born in the United States. There's a primary existence of Spanish being used as a secondary language, but there are also many, many others. And we cannot mandate that every policeman or every state employee be able to communicate in every language, but we have to continue to lift this issue up in a variety of ways. I was influenced in context of this issue and others. I was influenced last week by Mr. David Schaefer. We kind of made a joke of his name because there's others with that same name. He said, our obligation is to listen clearly to the person in mental health crisis and to respond quickly with appropriate services. I thought that was very insightful, and it's something that has been helpful to me.
Quick reference for anybody who was concerned about the language part. Where is
It's
it?
on page 9 on 177, but it's set out in the bill in a number of other places where we want to lift that issue up. Do you want to add anything at this time?
No, I just wanted to make sure.
Yeah. We have accepted a couple of other offers about minor definitional changes, but the primary definitional goal about mental health treatment services being set on the bill is for specificity. And I don't know if I mentioned it last week when we talked about the specificity of the definitions for mental health services being necessary in order to enforce parity, but there's a federal court case out of California where the court has said, Witt versus Governor of California, the federal court has said that if you don't have a precise definition, there's no way to enforce parity. That's an oversimplification of the federal court case, but that's what I read into it. And I think that the national discussion coming out of the Trump administration enactments in December 2020 for enhanced parity provisions, that case and the moving federal law towards enforcement of parity is what we are trying to do. We have added language on behalf of the Hospital Association in several different ways. At their good suggestions on page 14, line 324, Hospital Association gave a specific language about ensuring subcontractors and affiliate responsible for management of mental health be in compliance. The same day reimbursement issue is set forth again, multiple places in the bill, but specifically on page 15 at line 349, as is the reasonable efforts on language. As we move forward on MLR, which is section 4, part 1, section 1.4, again, some of the hospital language we've adopted there. But we also have been studying with Betsy Howerton's help, who's been helpful in every way, the Code of Federal Regulation definition of MLR calculation, whether it's gross or net, and to extent to which we can analyze that is to a certain extent set forth in the Code of Federal Regulation. And that's an ongoing discussion that Chairman Jones is leading, because the mathematical calculation about whether or not we are in compliance with medical loss ratio mandates that's been a mandate for over 10 years now is critically important. I think we said last week that Georgia was an outlier on making this definition. Moving forward, past the MLR manner changes, we come to workforce part 2, which begins around page 30. Serviceable cancelable loan. We got yesterday a very detailed memo from Lynn Riley that we're studying. We have not inserted amendments yet in the bill, but she has a very good set of criteria that they look at in general for serviceable cancelable loans. What do we have a residency requirement of time? And how do we manage, if we choose to manage, the criteria of folks delivering mental health services that degrees came from other states? Those are just examples of issues that they wish us to consider. And to a certain extent, I'm fairly confident that the Student Finance Commission has internal rules and regulations consistent with other cancelable loans. And that's really important, new information and new direction. Do we have to add that into the statute, or can we simply allow student finance to adopt their other rules and regulations in relation to workforce issues? Because as we know, workforce issues are at the very forefront of every discussion. Beginning on page 37, in relation to creation of the minimal data survey, which is very important in terms of really understanding where our folks are providing services. We have added some definitions there. We're requiring folks to tell us whether or not they accept insurance, and what kind of insurance. And I think that's a good amendment. We also have added back in this general area about workforce, we want to know, not only do you have an identity with an underserved area, but are you committing to serve the folks in the underserved area? Can we, and I believe we can, and we're suggesting this is an important amendment, that if we're going to cancel your loan, and if you're going to an underserved area, that means you're required to accept Medicaid and Medicare. Now, I think that's an important amendment, and I'm interested if somebody can talk me out of that in some way, because if we're going to give you a cancelable loan, shouldn't we, as a minimal expectation, expect you to accept Medicaid? We're moving into part 3, involuntary commitment, and the first part of that, which begins on page 38, is assisted outpatient treatment. There's a lot of very good discussion going on, and we'll be having ongoing discussion with the Commissioner of Behavioral Health, who is setting forth her pilot program first in Muskogee. We are not making any changes to that program at this time. Last week, as we said, we deleted a few inconsistencies in it. We are having good discussion about the statewide repository of information of persons who are the very subject of a whole lot of energy and a whole lot of attention. And that is what we're calling the familiar faces, the repeat ER visitors, the folks that are in chronic in and out of service. We are thinking of good ways to support that effort and to make a data set that's available to law enforcement who are picking up these people and to healthcare. And we are also keeping in the language right now that the sheriffs are required to continue to provide subsequent transports. I know that's an active advocacy activity from the lobbyist for law enforcement, and Kevin Tanner and I had a long conversation last night as he was driving around North Georgia for all his jobs, that we were going to continue that conversation. It's an important conversation. But I asked Commissioner Deckmeyer, who I was very impressed with last week, who's on our commission, I said, you want to remove the obligation of law enforcement to provide the subsequent transports after a patient presumably has been stabilized, but has been moved to a second service entity. What is your solution? Are we simply going to say, good luck, hope you can work it out? Or are we going to dictate a specific solution? You must contract with the private transport folks. But I wasn't comfortable taking it out. And when I say we, when I say me, I mean us. you, Chairman Jones, and Kevin Tanner, we've made these decisions collectively in a very coordinated way, in my judgment, and very helpful way. We aren't satisfied to take it out, and we're continuing to talk about it. We've amended the duties of the Office of Health Status and Coordination and Services and Coordination. We've added some duties there. We have streamlined, I hope, the duties of the Behavioral Council, and we are moving forward in a different way. I've gotten a kind of a color-coded matrix of all the different councils. I haven't completed what I'm going to recommend to the committee, but there is some duplication. These are councils that have been created statutorily over time. We're not creating these new. We're analyzing what the authority is today in the Behavioral Council or in the Commissioner's office or in Grant Thomas's office, and we're doing continuing work to figure out who has the best opportunity and authority to coordinate services to make them effective. In my long political career, there has been a discussion every year. How do we coordinate services from this obligated agency and this obligated agency to prevent the silo reality? And I think that's something we are still working on. I have highlighted the issues that we are ongoing in our discussion. One final issue I want to highlight for you. The four of us decided for this period of time to remove the Pediatric Registry that was set forth. That is an ongoing discussion. That is a little bit of a heavy lift, perhaps more of a heavy lift than the adult offender who is already in the criminal justice system for many reasons. Private medical records, obviously throughout the bill, we say any private records have to be protected from both based on state and federal law. HIPAA is reality, whether we say anything at all about this. But the Pediatric Registry is something we're going to continue to look at. It is an issue. The frequent flyer child is an issue coming in and out of the ER. We're not done with it. We have removed it at this point. Chairman Jones, what can you add that I have not touched on, please?
I think for the sake of brevity, and also I know that the chair would like to get to questions, I'll go ahead and I'll hold my comments, assuming that some of the questions may bring those out.
Representative Mathiak.
Thank you, Madam Chair. Can you go back and talk a little bit about children? The reason I'm asking that is everything that we hear around here, the earlier the detection, the better, whether it's autism, any syndromes that we see. So I agree in protecting children because we don't want them labeled. But I don't want them getting lost in the system either. Can you help me with that?
It's a really important discussion. Chair Dempsey has been chairing a study committee, and you have been involved in it, Chair Cooper, on early childhood intervention. And we have realized that the extension of Medicaid and the extension of early periodic screening diagnostic is absolutely should be enforceable and is not enforceable right now. We have made strides. I'm very confident we have made strides, but we have inconsistent policies from the CSBs.
Right.
Some CSBs are very cognizant of their federal obligation in relation to EPSDT and Medicaid provide for young children, and some are not quite as cognizant. That's one problem. Another problem that I think is solvable is the managed care organizations, coordination with DFACS, coordination with behavioral health, and the payment system by Department of Community Affairs. How much do we pay for intensive Medicaid paid services for children who are in severe mental illness crisis? That's an ongoing discussion, and we have the Governor Kemp raised by 10% the payment reimbursement for care facilities. It's an issue that I've struggled with in a wide variety of ways. Our recognition and our services are improving, but we have an inconsistent delivery of services. And this bill is helping in a variety of ways.
I can chip in a little bit on that, and that I haven't had a chance to tell Representative Oliver. And you told me to talk to the GEARS people because there was question about birth to 3 years of age, what kind of therapy? You know, the psychiatrists are telling us that, you know, what kind of therapy? And the ASCs said that they start dealing with children with autism at age 3 and then with mental illness at age 5. But before that time, that they don't treat infants and all. And so GEARS said that there is a new system, which is basically working with the family and the child. And they are doing a training program, but it's not ready to go. So when we get together again, I'm not sure how those people are not going to be available for probably another year or so to get ready for it, to provide the kind of services and the number of people across our state that would be able to treat. So, I mean, that's the kind of thing that comes up. How do you put that in the bill when, you know, people are not ready to treat them yet, and we don't have the training, and apparently it's a very specific type of course.
This may be a good or bad way to highlight the issue. Alabama has done a great job with early children interventions.
So,
Can I have a follow-up, Madam Chair?
sure.
Okay.
I mean, they're there.
Do you believe that the data sourcing will help too in identifying specific problems? I think about our kids that are in foster care and some of the cases that I've been involved in, and moving those kids around does not work, period.
The data,
End of story.
the data sourcing is essential. It's an
Yes.
essential part of this bill. We have a Georgia Tech professor as a workforce expert in healthcare delivery services. She says we do not have adequate data to make the improvements we need to make.
Yeah. and For the committee's sake, I want to make sure, Chair Mathiak, that it's one thing to talk about the treatment, and analyzing that treatment, and then getting the data that's associated with that treatment so we can see the trends. And then it's another thing to talk about, we had in here a pediatric registry. I think one speaker last week called him a high flyer, or high number of flyers, 60, 70 times within. So I want to make sure that there's a very clear distinction. Chair Oliver and I absolutely agree, as I believe Chair Cooper does, that we want to do, I'll say, the former, and make sure we do that properly and drive that as early as possible, given, I'll say, medical advice. At the same time, the other side, where Chair Oliver discussed about the idea that we have taken out the pediatric registry, that was due to the fact that there's a significant amount of privacy issues that we're trying to, let's just say, grapple with. But I want to make sure that the committee is assured we understand the former is very important for us to get more successful within Georgia,
Right.
especially with our younger children.
Right. I'm very hopeful that the data is going to make a difference. And like I said, if we can stop moving these kids around, that's going to make a difference. too.
You're 100%
Consistency.
Okay,
Thank you.
other questions from the committee? Anybody online? Roy? Okay, oh, sorry, Representative Newton.
Thank you, Madam Chair. On page 15, where you did talk about the MLR, and I know that is an intense accounting term filled section, Federal Registry and all the references there. I did notice a couple of things that were interesting. I know the goal is to have, and instead of medical loss, I like to call it medical spend ratio, because I would assume if you're paying nurses and behavioral health specialists, that is not a loss, that is a spend. But I understand the terminology on this medical spend ratio of 85% of the amount of money that the state provides. When I look at that, though, I see a couple of areas. One would be on lines 379 through 383 about community investments. I would love to see I would almost love to see that separated out to where community investments was separate, even though it might count toward the 85%. It would be helpful to know, because I know the hospitals that are trying with the workforce challenges and the financial challenges for nurses and everything else, it's a huge thing that we need most of our money going toward that. The other piece of it was on the next page under section E, I think there's some exemptions for subcontractors. I wouldn't accuse any ill will to anyone, but subcontractors that are wholly owned and therefore exempt from the MLR reporting, which I think is section E, where I guess I would see a difference between a subcontract to a different entity and a subcontract to an entity that's wholly owned by the care management organization. It could easily defeat the goal of an MLR, a medical spend ratio target, if there were wholly owned subsidiaries that were those subcontractors. Just a couple of observations. I don't know if you have any comment about it. I know you understand the accounting better than I do.
Yes, sir. Dr. Newton, you are on to some of the areas where we're, I'll say, most concerned on the MLR, or in your case, the MSR. Actually, I like MSR a lot better than MLR, to be completely frank with you. Lines 381 to 385, as you see, that's new language. And we're still, I'll say, massaging that language. For instance, you talk about separating it, which I think is important, because I think there is, I'll say, direct spend, and that could be considered, I'll say, indirect spend. The other thing that we've been tinkering with is a cap on that type of spending.
Okay.
So something along the lines of, and for everyone listening, please don't put this in, but 3%, 4%, but
Right.
something that is clear, it's important, but we want to make sure direct spend is much higher than that, I'll say, indirect spend. So separating it, putting a cap on it, and then obviously being able to continue to analyze what is the right number there in terms of what that cap should be. In terms of your recognition in subsection E, you're spot on. We need to make sure that, especially given the vertical integration that we've seen in healthcare, that vertical integration has caused it where, following GAAP accounting, so it's not as if anyone is doing anything untoward, based on the fact that we have so much vertical integration, we do need to make sure that each chain within that vertical integration is, I'll say, held accountable, as opposed to the entire, say, 5 levels. At that point, then accounting does come in, and you have a way to possibly demonstrate a medical spend ratio that maybe isn't necessarily the medical spend ratio. Okay.
Well, thank you. Thank you, Madam Chair. I appreciate that. I know that the demand for these professionals is across the nation. Georgia hospitals and healthcare systems are going to have to really spend dramatically to attract and then retain the people that we need. And I appreciate you. 85 seems a little, maybe on the low side. I know you mentioned some others that might have been 90 or 95. Yes, ma'am.
I like medical spend ratio a lot better too.
All
Thank you. One of the issues is what does CMS have to do in terms of a waiver from CMS? DCH and waiver issue is something that we're trying to understand with this new language too. Waivers are complicated, and particularly Georgia right now, they're complicated based on kind of a conflict going on. So we're thinking about that a lot. Again, this is new language as we intensify our drill down nationally on MLR. What I'm confident about is that it seems to me on the surface that Georgia is an outlier, and we are not drilling down the extent to which others are. I don't like the fact that it looks like we may be averaging performances of 85. That's something that I don't think we should encourage or need to prohibit, in fact, more specifically. You're commenting and helping us drill down on a very, very important part of the bill.
Thank you so much for y'all's work. Yes.
And Dr. Newton, I do want to note, the bill does say 85 or negotiated, meaning better or negotiated. So if hypothetically that CMO wants to come in and bid more aggressively to an 85 and a half, an 86 and a half, and 87 for that matter, they may see that as advantageous to garnering the state's business. So we felt as if it was better to put 85 as the floor and then permit the increase based on what that bid could look like. So we're hoping that we see numbers higher than that, to be completely frank with you.
Thank you.
Okay, Representative Hutchinson.
Thank you, Madam Chair. I just had a question. You said that the inconsistent delivery of services would be improved with this bill in a variety of ways. Has anything changed from this one, from the last one, as far as intercoordination, and that would improve it?
Who do we assign the responsibility to enforce the coordination that already is statutorily set forth? Is it the Behavioral Council, or is it the Office of Health Strategy that is new? Both of those are created. I believe this bill in several specific ways moves the authority to specifically the Governor's Office of Health Strategy. It's my hope that that's going to be coordinated. It's my belief. And the intention of us putting that language in there to put that leadership in that office directly will serve as directly reportable to the governor in a more efficient coordination fashion. That's our goal. If there's other specific suggestions you have about that particular entity or the Behavioral Health Council, again, these are previously created entities for the purpose of creating more coordination. We're very open to that because that's very key. I used this example last week, but I'm going to repeat it. A Medicaid child in foster care services are delivered based on the managed care contract, based on the caseworker of DFACS, who is the person who's making the medical decisions in lieu of the parent, and DCH that sets the rate and approves the rate. I think that's a very difficult entity to coordinate, and we have to do a better job.
Agreed. I would follow up. In the study in the very end, is there any way we can add that they look at how much money we're spending across the spectrum for onboarding and administration of mental health dollars in the state of Georgia? The information I've been trying to get for 4 years. Is there any way we can implement that in here?
I'm happy to look at that for you. I know that Medicaid DCH says they have a 2% administrative rate. They say that generally.
I doubt that very seriously.
I can't
Very
verify it,
seriously.
but I know that's what they've said over many, many years. I'm happy to look at that again. Thank you.
All right, Representative Kelly, welcome to the Health Committee. Do you come with a specific question? Since I haven't seen you before, I thought maybe you had some that people had talked to you about. Oh, okay. All right. So that's what it is. Okay. Do we have other questions from the committee? All right. I think that's, having gotten this, I'm sure they're all going to read it carefully. So we will go to people that want to testify. Okay. Representative Newton.
Thank you, Madam. Just to follow up on Representative Hutchinson's administrative slight disbelief at 2%. Were you looking for a way to estimate the administrative costs put on the providers or just at the level? Because I believe you're absolutely right. If you're talking about the audits that you mentioned, the admin time, it would be interesting to also get, and I know some paperwork reduction acts in the past federally have tried to do that, to try to estimate what the additional demands are placed on providers like Representative Hutchinson's that she's associated with. It would be a valuable piece of information, and it also, by putting a spotlight on it, might encourage them maybe to share audits or the similar audit forms for our providers, so that they don't have to have a different form for every insurance plan that they take care of. So by putting a spotlight, it could possibly, just a thought.
I was talking about the administration of mental health dollars, not the providers. I feel like if we can get a hold of the administrative costs, that would trickle down to the providers, and it would be probably less expensive to manage their program. But I suspect that if we have DBHDD, we have all the CMOs, DFACS, DJJ, all of those entities have some portion of mental health in their budget. And that's the number I'm trying to get, is how much, and I doubt very seriously it's 2%. All across the spectrum, where all of them are really regulating the same services. I just want to know what the numbers are. And I think they'll be surprising, because that's why I can't find them.
Happy for any specific suggestion you may have to look at that and discuss it further with the committee.
Representative Seabaugh.
I'm
Sorry. Go ahead. No, you finished answering her.
As I've gotten deeper into this bill, I think one of the challenges is, and Chairman Lumpton's bill yesterday speaks to it, statutory versus GAAP accounting. When you try and mix government accounting, and I'm going to call the real world accounting, it's Hebrew and English. And it's numbers, but that's about all that's there. So when we're dealing with our own businesses, we use GAAP. And GAAP, I think, is much more practical in terms of how you run a daily operation, government or not. Statutory is much different. And that's where I think you get this massive incongruency, because I think anyone would say 2% is just It's just not reasonable. That's not, it doesn't pass the straight face test. Using statutory, pardon me, GAAP, my hunch is you'd be probably around 14 or 15%. And then as a business owner, you're going, that's about right, because I have 2 admin assistants that all they do all day is do insurance filings. They do all the filings I need to do to keep my business running. That's not 2% of your overhead. I'll guarantee that. But in GAAP, it's in the double digits, and statutory, it's probably in the single digits. And I do think we probably have to look at making sure we're looking at the numbers the same way.
I think we could spend a lot of time on this because it's an irritation to everybody. The history of how healthcare systems developed is set forth by Dr. Atul Gawande, who's somebody I follow. You may know some of his work. We developed a healthcare system based on insurance, and Europe did something totally different based on World War II. If we could dial back a little bit, maybe we would have a different thought process, but here we are.
Representative Seabaugh.
Thank you, Madam Chair. Representative, you talked about subsequent transfer of patients and law enforcement being tied up with that. And I know with the workforce challenges that law enforcement has right now, I just wanted you to know there are public-private models out there that are working, and I'd be happy to talk with you offline about
We
that.
need some help on that. Of course, in DeKalb County, we've had a crisis mobile unit, and we've inserted as one of the amendments here that crisis mobile units can do transports. That's a good example of something where in X percentage of the state, they're able to do that. So I'm very interested
Right.
in examples of where that might be working better.
Yeah, be very happy to talk with you about
Thank
that.
you.
ASAP, I would say.
Yeah.
Okay. Representative Dempsey, I know you were in appropriations and meetings like that. Do you have just questions in general you'd like to ask?
We've been talking about early intervention for infants and young children, and glad that you're here, and we will continue to protect that in the bill.
All right. Any other questions? Anybody on Zoom? Okay, we don't have any questions. So as I put out that if you have not testified before, we have a sign-up sheet. If anybody did not get a chance to sign up, okay, we'll add you to the list. I'll ask for hands. Okay, but I'll start with people who signed out. Callan Wells, if you'll come up and identify yourself and who you're with.
Hi, everyone. I'm the Gears people that Madam Chair discussed. Thank you all so much for giving me the opportunity to speak. And I wanted to take just a little bit of time to kind of dive a little bit more into the early childhood piece that keeps coming up and talk a little bit more about why it's so important and what the services look like. Last fall, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national emergency in children's mental health. As evidence, they cited a CDC report, which found that between March and October of 2020, emergency department visits for mental health emergencies rose by 24% for children ages 5 to 11 years. So that means that children as young as 5 are visiting emergency rooms in mental health crisis. While this report is new, an increasing amount of research over the past 30 years has pointed to the importance of focusing on the social emotional development of very young children starting at birth to build children's resilience and prevent mental health emergencies. Children do not wake up on their 5th birthday and suddenly have mental health. Mental health begins at birth and is shaped by a child's early experiences and relationships with their caregivers. Obviously, there are genetic components as well. We know that young children experience adversity and disruptions in their primary caregiving relationships. Infants and toddlers are overrepresented in foster care and 3 to 4 times more likely to be suspended or expelled from preschool than their K-12 counterparts. The adult mental health crisis is also affecting our children. Consider this. The 25 to 34 year age group is experiencing the most opioid overdose deaths. The average age for first-time parents is 26 to 31. When young children experience trauma, it affects their brain development. The first 5 years are the most critical period for brain development, and disruptions during this time have lifelong impacts. There are developmentally appropriate approaches to therapy in early childhood. This type of therapy is known as diatic therapy because it always includes the dyad, so the caregiver and the child. Young children are not medicated, and they are not given a label that will follow them through their whole lives. Therapy for very young children focuses on the relationship between the caregiver and the young child, because that is where children find healing and resilience. In 2019, a House study committee chaired by Representative Dempsey focused on early childhood social emotional health. That committee produced a series of recommendations to improve Georgia's systems to better address the mental health needs of young children. Many of these recommendations have already been carried out, including the creation of an infant and early childhood mental health director at the Department of Early Care and Learning, the formation of a cross-agency task force focused on early childhood mental health, clarification of Medicaid billing procedures for the therapeutic services for very young children, and the formation of the Georgia Association for Infant Mental Health, which will lead workforce development initiatives ongoing. Already, there are plans in place to have 85 clinicians trained in developmentally appropriate therapy practices by 2023, thanks to investment by multiple state agencies and private funders. These advances begin to build the availability of services and trained professionals who can serve our youngest children. The Mental Health Parity Act represents another turning point for early childhood mental health in Georgia. For the first time, a bill of this magnitude meaningfully includes young children and their caregivers in the mental health system of care. We have an opportunity to take care of our babies and their families in a comprehensive, easy to navigate system of care to avert mental health crisis and to set our families up for a lifetime of loving, joyful relationships. GEARS supports the passage of this bill with the meaningful inclusion of infants and caregivers throughout our mental health system of care. Thank you. And I'm happy to answer any questions.
Okay, thank you. Kim Jones.
Good morning, Madam Chair and members of the committee, and thank you for this opportunity today. Thank you, Representative Jones and Oliver, for carrying this bill, and I want to thank the speaker for his work in getting this bill forward. I come before you today as an appointee of the Governor's Behavioral Health Reform and Innovation Committee. I'm also the ED of NAMI Georgia, also co-founder of the Georgia Mental Health Policy Partnership. But most importantly, I'm the proud mother of Luke Jones, who is a child with a mental health condition. This bill before you is the cornerstone and only the start to reform mental health here in Georgia. Thank you for having us all here today. It's important to many of us who you see here. We are here in an effort to make Georgia a top-ranking state for mental health. Please know that there was a process that was accumulated in the 74-page bill over the last 2 years. The governor's office, the speaker, the lieutenant governor, and the chief of justice all appointed members to the commission that has diligently worked to produce the bill that sits before you today. I want you to know that the bill before you was broken up into 5 committees, and it was carefully crafted by expert members from the Governor's Behavioral Health Reform and Innovation Commission. The bill represents the work with ambassadors from the mental health community, getting nearly 20 leaders of mental health advocacy groups united. Putting aside our own opinions, our egos, and our interests was no small feat, but it was necessary in order for us to support a bill that will help the hundreds and thousands of Georgians we represent. The process was a delicate balance that carefully considered the various interests represented. It was a hard process. We argued, we sweated over the issues, we negotiated, and we compromised up until the moment the speaker spoke on the Capitol steps at his press conference. Madam Chair and members of this committee, we want you all to understand that this bill is the compromise bill that we advocates agree upon. Leading up to the speaker's announcement, and even now, we meet weekly. We held press conferences and developed a united vision to transform mental health and substance use disorder. I hope our advocacy work and the compromises this bill reflects are respected, for behind me and all across Georgia, there are hundreds and thousands of Georgians who stand to benefit greatly throughout this bill. As a member of the commission, I also want to remind you that this is an important beginning to the mental health reform process, and it is just the beginning. This bill is the cornerstone of bills to come and the work the Governor's Commission. As soon as this bill passes, the commission will begin to work again and will result in a 2023 mental health reform bill. Our goal is to go from ranking 48th in the United States to ranking in the top tier for mental health. We want to underscore that everything brought to us has been considered. It has been negotiated and it has been compromised. We thank you very much for your work today, and we welcome improvements to the bill, positive tweaks, but we ask that you carefully consider the delicate compromise and negotiations that have made this bill what has united us as advocates today. We welcome other mental health advocates to join us in the Georgia Mental Health Policy Partnership after this session concludes. And we as NAMI Georgia and the Georgia Mental Health Policy Partnership support this bill wholeheartedly. Thank you for your work today.
Thank you. Mary Rose Nunnup. Did I get it right?
Close.
Okay.
Nayon. Good afternoon, Madam Chairman and the committee. My name is Mary Rose Naom, and I work with the Policing Alternatives and Diversion Initiative here in Atlanta, Georgia. PAD, which we lovingly refer to the agency, has provided an immediate response to people experiencing behavioral health concerns since 2017 and routinely works with law enforcement to reduce incidents of arrest while connecting people with more appropriate care and supportive services. We are concerned about the outpatient commitment provisions in this bill that would eliminate the imminent harm standard. Eliminating the imminent harm standard is counter to the bill's stated goals of achieving mental health parity. Currently, an individual in mental health crisis must present imminent harm to themselves or others in order to compel treatment against their will. As written, this bill would make it easier to bypass an individual's ability to choose their own behavioral health care. In a medical context, this happens only in the rarest of circumstances, at which point a medical advance directive would carry weight in determining an individual's treatment. To achieve true parity, an individual who has a history of mental health needs should be afforded the same rights. House Bill 752, which is the Psychiatric Advance Directive, would provide individuals who experience mental illness the opportunity to provide input on their care if unable to do so at the time of crisis. And we feel strongly that creating the capacity for psychiatric advance directives, not taking away important procedural safeguards like the imminent harm standard, is a more appropriate way to address concerns around treatment without depriving an individual of their right to choose. We're also concerned that the bill as written may expand a law enforcement officer's ability to transport someone against their will when they have not committed a penal offense, and concerned about how this may impact an individual's right to due process, the potential for an increase in unlawful detention, as well as the use of force. Thank you so much for your consideration, and to all of those who have worked so diligently on this bill. And we hope our concerns can be addressed as this important legislation moves forward. Thank you.
Thank you. I will tell you that the advance directive is my bill, and I'm going to do everything possible to make sure that that passes. It's only taken us 14 years to get to this point. And so I think everybody's finally in agreement and of how that looks. And I think Representative Oliver would like to say something.
We're having ongoing discussions about this. We've looked at an Illinois statute that has some opportunity for perhaps compromise, and I ask folks that are looking at this to look at the Illinois statute. I also want to extend thanks. One of the amendments that came forward is that we drill down more on the homeless population, which really demonstrates this eminent word to me in a very concrete way. Chairman Dempsey has been looking at those issues, and I think in my mind of the homeless population when I think of the word eminent, which is a part of it, but something that I wanted our bill to reference, and it does now on page 58, line 455.
What was the line again? The line number?
I think it's 1455, excuse me, the cutoff of the one, 1455, line 58. That's my red line bill, and I can double check.
It's 455.
1455, I think.
Some of your numbers have been off before, so. No, I don't think that's where it is.
It's somewhere.
It's I was gonna say
It's,
that.
I'm looking at it. It's there.
Yeah, you beat me to it. Okay, try 45 and 46. There's a homeless list. Thank you.
Thank
Amber.
you, Amber. Saves us again. Amber saves us again.
So.
Yep.
Okay. Right, we have that. Okay, Sheriff Norris, I know that you wanted to speak, and then I'll let everybody hold up their hand, that the other people. I just happen to know you wanted to.
Now, Madam Chair,
Yes.
so you have given me a increase in stature by calling me Sheriff Norris. Thank you
You're
for
not a
that.
sheriff?
I am the Executive Director of the Georgia Sheriff's Association.
Oh, I'm not going to listen to anything you say from now
Well,
on.
let me go down.
I thought I had to be careful in case I got arrested
No,
or
ma'am,
something.
you're not getting arrested.
Okay.
And let me say this, we know that this has been an issue that we all have talked about forever. And Madam Chair told me this morning, I think, she just didn't know what she was going to do with us. So I'm here to say that the sheriffs want to support this bill and will support this bill. We did offer several amendments to the initial bill, some of which I think have shown up in this substitute. But I did want to point out just a couple of things in the bill, and I want to talk a minute about transportation. If I could call your attention to page 44 of the bill, 37-1-124.1, for us in law enforcement at the local level, we are the ones, the chiefs of police, their police officers, the sheriffs and the deputy sheriffs are the ones that show up. We're the ones that come when you call 911, whether it's a case of a mental patient or a mentally ill person in crisis or something else. So I'm on page 44, line 11122. It's just that section I'm gonna reference. So there's nothing specific other than to say, since we are the people on the streets, the Atlanta Police Department, sheriff's offices, police officers all over the state, we are the ones on the street. We are the ones that will get the calls. So I didn't see it in here. I think I suggested it. And it may be covered, but any sort of database that shows up with people who have been entered in the database that have behavioral issues, it would be helpful for us to be able to access that in answering calls. It would make people safer, both the officers and the citizens. So any consideration you might give there to making that clear would be helpful. Yes, sir.
Can you say that one more time? Neither one of us was able to exactly.
You've got a database of individuals that the CSBs and others have identified that are in need of assistance. We just, at local law enforcement level, we need to be able to access that to know who these people are so that we can help them. So when we answer a call, we might know that this person is residing here or this person is in this particular community-based facility. I will say this, in the past, the way when community-based services became more prevalent, the way in many cases the sheriffs found out that there was a home there trying to assist those with mental in crisis was calls for service. And a lot of times at that time, and I don't know how it would be now, a lot of times those places were in neighborhoods and zoned appropriately, but they were there. They just didn't know it until they started answering calls. So this would help us know in the beginning where these folks are so that we would respond to a scene knowing that that might be the situation we're encountering, if that makes sense. It makes sense to us. So if we don't have access to that information, we would hope that we could have access. And I want to talk a little bit about transports, not a whole lot, but I want to, in just a minute, direct your attention to page 49, lines 1255 and 1256. But first, I want to mention this. We, in anticipation of this important matter being discussed more prominently this session than ever, even though we've been talking about it forever. We asked the sheriffs a little bit about transports, just some basic information. And we asked sheriffs to report to us in the calendar year 2021, just on the number of transports and some basic information about transports. I had 72 sheriff's officers tell me during that calendar year 21, there were 3,992 transports, roughly half the state. Of that, there were 4,659 deputies assigned to those transports. Number of miles traveled were 388,781 miles. Number of hours that it took to do these transports, 13,850 hours. It took a deputy sheriff away from that sheriff's office to do this. And I'm not saying this to say we won't do it or they won't do it. I'm just trying to set the perspective for y'all because I got fussed at by the chairman earlier. And then finally, the number of hours at the emergency receiving facilities for the deputies was 1,196 hours that they stayed at the emergency receiving facility trying to provide that person with that trip in that facility. So I say all that to say, and this is partial data, it is a lot. It is a lot. You all know, we've talked to you every year for the past years about how difficult it is for us to hire, but it's also difficult for everyone to hire right now. So we're struggling. But if I could direct you to lines 1255 and 1256 on line 49, this language followed, and I wrote this language, and after I wrote it, and we thought it was appropriate for our end, the sheriff's end, I got calls from sheriffs wanting us to look at it again. So what I would ask that you do, and I think I've included this in my previous email on amendments, we would ask that you would strike line 1255 in its entirety, and then 1256 through the second and. What that would do, that language is, shall be responsible for ensuring the safety and security of such person during such emergency evaluation and examination. Everybody would automatically get that person there in a safe manner. And if that person happened to be combative, they certainly are going to stay on the same, but it is unreasonable to expect deputy sheriffs to stay there any longer than it is to deliver that person, which is what the code says. So that was my language. And my sheriffs came back and said, after thinking about it, we don't like that part of it. There's another thing. This particular code section, this particular code section deals specifically with the good idea and the clarity in the law that an officer does not have to tender charges on minor offenses and can take that person directly to an emergency receiving facility or a physician in his county or her county or the next county. So that allows some of that diversion away from jail and charges. But in the case of the sheriffs, the sheriffs, y'all might know this, the sheriffs are the ones, even though it says in the code, any peace officer can do this, it's generally not any peace officer. Where there's not a public and a private agreement to do this, it is the sheriffs everywhere. I'm not to say that in the city of Atlanta, a metropolitan area, or even a smaller city, a city police officer might do it in the city. But generally speaking, we're traversing the state to get this person some help. So in the case of a peace officer that does not tender charges, but yet takes this person for the appropriate evaluation, it is the sheriff's hope that, and you've got this language in there, the sheriff's hope that you will at least continue with this language, which requires the arresting or the agency employing the officer who does not tender charges, but yet provides this person a ride to an emergency receiving facility to follow up and do the subsequent transports. Does that make any sense to anybody? If we don't do this from the sheriff's perspective, we will have police departments bringing people to physicians or emergency receiving facilities They would rightfully leave because there's no need, if we change the law, to remove that security, stay there at the scene, at the site. But the next thing would happen is if that person is 1013, the sheriff's going to get that 1013 order. That's who's going to get it. So we think it's a good idea to avoid arrest. And I've said this many times I said it in the committee the other day. Sheriffs do everything they can to get people out of jails, the ones that need to be out. And in a lot of jails, there's some really good inmate medical care provisions, and part of that is mental health. But a lot of places it's not. So we need them out of the jails if we can get them out, and we can get them to an appropriate, safe place. So if you would consider that that removal of that language, I will say this, my friend, and I say this seriously, Butch Ayers is here, and he is the exec of the Chiefs Association. They don't like this language, where the language that you would have, whatever the employing agency of the officer that did this would have to perform the subsequent transports. They don't like that. And their ideas is to come back and say, we'd like a public-private relationship to let these people be transported the way they should be, not in the back of a patrol vehicle, but in a medical van of some sort, transport van of some sort. So we know there's a lot, there's a lot in here. Y'all have done some great work. Thank you. But we are truly about doing all the transports we can do.
Okay, Representative Oliver has something, and then I have a question from committee committee member.
Thank you,
Representative Oliver.
Madam Chair. This is a valuable discussion because I don't understand it. I don't understand what you're asking us to put in and what you're asking us to put out. And we'll get to that.
Okay.
What is your solution to transports? Have you given us a solution?
Well, it's a money thing.
No, who do you want to do it?
We would love the EMS providers to do it.
Okay.
We would love that.
How many counties have crisis units that do transports?
I do not know that answer.
I think that'd be really helpful information. Your details about how many hours and all of that was interesting. You said 72 sheriffs responded.
Yes, ma'am.
I'm curious if any of those 72 counties had mobile crisis units that were available to them. I keep hearing that people should be doing public-private partnerships on the local level, which of course is an obvious answer, but I can't figure out where that's happening, because it is happening.
It's
And
happening in the Cobb area, I can tell you, and it's happening in the Athens or the Oconee County area. And
What I want you to do is to give me that in writing. Where is it happening in public, private, and where are mobile crisis units in whatever counties doing the transport? Because that'll give us some real guidance as to what are options that have been developed locally. That would be a really good way to help us look at solutions. How many counties are doing it other than by sheriffs? How many are doing, and who's paying for it? I mean, we have a grant, we're changing things in the bill that allows the Criminal Justice Coordinating Council to award grants in a variety of ways for co-responder programs and other programs. And what that means as a practical matter to me is that one of your 72 county sheriffs could say, oh, okay, here's a grant. And I'm just curious what activity is going on to find solutions, because you and I have been around long enough. How many hours of our life, and we don't have that many left, have we spent talking about transports, and we've never gotten to a solution? Excuse my tirade.
Okay.
I didn't consider it a tirade. I considered it the discussion we've had for 25 plus years.
With no solution.
With no solution.
And I was nicer this morning, and you said I fussed at you. Goodness gracious. Representative.
Lady,
she's mad at me.
if just a couple of things on it, having been in those areas where the behavioral health patients are brought to an emergency department in particular, there's a couple of different, a lot of them come on their own, some come by ambulance, some are brought by family or friends appropriately. There's a smaller percentage, I know you said that was partial data, there's a smaller percentage brought by law enforcement, usually because they've either been combative or just wouldn't come with anybody else. And it was the only way to get someone the care they needed. A lot of times when they're combative, they're also combative with our nurses in the emergency department. And so to take out ensuring the safety and security line, I know that police officers, unless somebody is really extremely violent and in chains or something like that and has been violent, but the police don't typically stay. But we kind of need them to stay long enough to get the patient stabilized, at least from a combative point of view. Would you consider after along the line, say 1256, where it says they'd ensure the safety and security of such a person during emergency evaluation and examination until released by hospital personnel? A lot of times it's an initial injection of a couple of medicines and things get much better, and then we can handle them in a normal behavioral health area. I think, but we do need the assistance of someone who's involuntary, trying to run away, sometimes trying to hurt somebody along the way, until the hospital personnel would release that. That would be one question. And the second thing on the transports, what we've heard from the EMS crews is that there is no way they can stop someone who's being involuntarily committed from grabbing the door and jumping out at an intersection. And I think it happens when we've tried to transport any other way, but with someone who has the authority to have doors locked from the outside, unable until you get to the receiving facility. There doesn't seem to be a public-private group that has that same authority to keep the doors locked on someone until you arrive at a more definitive place. So those are my two questions, or two kind of concerns about eliminating the safety and security and completely changing the transport, even though I know it's suboptimal.
Well, to answer that, I wished I had not included that information or that language to begin with, and it was a little too broad. And it is, we have throughout my entire career with the sheriffs, and I've had a longer career than that, throughout my entire almost 27 years, periodically throughout that career, and I say not frequently, but occasionally, I would get a call from a sheriff where, in this case, state hospitals would actually not allow the deputy to leave. They would lock the deputy in there until they decided it was time for the deputy to leave. And our response to that is that's obstruction. And it almost, in a couple of instances, it almost came to warrants being taken for these people. So the language doesn't, I mean, removing the language doesn't mean that that officer is not going to stay there, that person is stabilized. It just means that wherever that person, that officer is, wherever that person is taken, that facility is not going to keep that officer there for undue periods of time. The other side of that is, in most of your hospitals, you should, if you don't, we should, if we don't, have hospital security that should do that. As far as I think on the part about the private partner, private-public partnership piece, and whether that private partner has the authority to do that, I don't think they do off the street. I do think they do once that person has been a civil commitment order from a judge or the physician's certificate has been issued. I think they do at that point. But I think, you know, in your case, you know, you live in our home area and we've got pretty good resources over there. That is not the case everywhere. Although I will say too, a lot of smaller hospitals don't have a lot of security.
That's absolutely right.
So we get all that, but this language is going to be abused if we do this. And we're going to be held accountable for, we may think the situation is stabilized and we can go, we leave, and we're going to have complaints. So we don't want that undue liability on the sheriffs.
Representative Hutchinson, you had a question?
I had a question. If we if those lines were struck, what would be the replacement? Like, who would be responsible for that?
Well, as I alluded to, I mean, that officer is going to stay there until that person is stabilized, but it's just unreasonable to keep that officer there much longer. So hopefully at that point, that person is medically stabilized to the extent they're not confrontational. And again, in metro areas, particularly the larger hospitals, they do have security. And in some places, the local police department or sheriff's office has somebody on that particular facility site anyway, not all places. So it happens different ways.
Right. So you said that normally the officer stays there, but I guess what we're worried about is what is outside of normal. Like who, if we struck those lines, I don't see a feasible, definite or what the options would be.
And Madam Chair, just as a way to start that discussion in a more productive way, my questions are how many transports are delivered by city police officers? How many public-private contracts exist to do transports in Georgia with either counties or cities or with hospitals or with private ambulances services? And finally, how many mobile crisis units do transports? That's a way to start the discussion in a productive way. I will give you my notes as to what I'd like to know. And that would be helpful for us to talk about specific solutions.
Representative Seabock, have you got an answer to that or?
Can you hear me? So there is a transportation model for subsequent transports from hospital to a more definitive facility for mental health patients. It's probably population-based. It may not work throughout the state of Georgia, but in our most populous area, which is the greater Atlanta area, we do have a solution for that, and I'll be happy to share that with you.
Thank you for doing that. Before you go, it's wonderful that you could tell us, you know, how many people you had transportation and how many times you transported people and all. And so obviously the sheriffs are very good at keeping statistics. You know, I promise you that we don't have anywhere near 13,851 pregnant women that they would have to deal with. So, you know, I got a little bill that moved across. Could you talk to the sheriffs and maybe get them to agree this year to the fact that we need some statistics on how many pregnant women we have? That would be a much smaller number. So I'm asking you to help. You know, last year they didn't want to tell us how many they had or anything. So I'm asking you to, since they keep such wonderful numbers on how many transports they do and how many hours they spend and all, if you could just ask them to tell us how many pregnant women that are incarcerated or in their jails and maybe what happens to them.
Madam Chair, would you like me to go over this report with you right now on this issue or wait to talk?
No,
to
I just,
sidebar?
no, just wait. I just thought I just wanted, you know, it didn't, we took it out of the last bill because y'all weren't happy with it.
Well, we have, and in all seriousness, yes, I know you want information. Yes, I have information because you asked me to get that information. And no, we haven't spoken about it because there've been this and other matters.
Yeah.
So I will speak to you about it. We're going to have that conversation, I hope, before it goes too far in the Senate. But
Right.
thank you for asking.
Yeah.
And if I may, Madam Chair, we are spending some time on this. So you've taken my mind to a data collection by the sheriffs where you were never able to tell me how many 17-year-olds are in your sheriff's.
Oh, no, I've got that too.
Okay, good.
ma'am.
We got a lot to talk
I've got
about.
that right here too.
Wow.
We got a lot
What
to
else
talk
can
about.
I do?
I
You got
know.
anything?
Because I just thought the sheriffs always said no about telling us how, you know, what they do.
No,
Well, and I tell you, wait a minute,
yes,
I
ma'am.
tell you, after listening to how many transports and stuff you do, I have a greater appreciation for what you did because you put it 13,000, whatever it was. So, you know, giving us that data really does help, you know, us appreciate the sheriffs more. And I love giving you a hard time.
Yes, ma'am.
Yes,
Okay.
me too.
Thank
Well, we'll follow up with these. Thank y'all.
Okay, thank you. Okay, and you. Okay, I am gonna let everybody, we can't go on this long with
Right.
everybody, so, because I want to get to anybody that wants to speak. Okay.
Hi, my name is Butch Ayers. I'm the Executive Director of the Georgia Association of Chiefs of Police, and kind of hard to follow that great speech by Terry Norris, my friend. Just real quick, I want to say the issue that the chiefs have right now is not the initial transportation, it's the subsequent transportation. Right now in the state of Georgia, everyone knows there is a recruiting and retention issue, and most police departments throughout the state are understaffed. Right now, 71% of the police departments in the state of Georgia have 25 officers or
Trying to
less.
figure out what the reality.
And then when you start putting that number, when you have to cover coverage 24/7, the actual numbers of officers per shift gets to be pretty low. So if you're going to take one to a subsequent transportation after they've already initiated and delivered the individual to a emergency receiving facility, then you might wait 2 days or something and then decide that patient needs to be transferred somewhere else. To call that initiating agency back in, take that officer off the street to conduct a non-emergency transport, I think is going to put a lot of, take officers away from serving their community. I know in talking with the Representative Seaball yesterday, there are public-private partnerships or other solutions. I know just even in the medical field, not with mental health, is if an officer takes someone or somebody arrives in an ambulance and they've been involved in an accident, that they have to go to another institution or hospital for a higher level of care. They're not calling the police department back in to make that transportation. This is one of the things that we want to be able to help individuals. And if you have somebody that's initially taken in by the police, once they're stabilized, I think one of the last things you would want them to do is follow up on a subsequent transportation to put them in a police car with another police officer and transport them somewhere else. But I'd be glad to work with members of the committee. And I think they're already aware of some of our comments, and I'll be glad to answer any questions.
Representative Hutchinson, do you have another question?
Yes, I agree with you with the subsequent transports. I have to disagree with you on the initial transports. The last time I 1013 somebody and we had to call for transport, they said, and I quote, and this was a sheriff, "I have 72 hours to get to you. You are the bottom of my priority list. I'll be there within 71 and a half hours."
Police.
Yeah, I'm just,
You
it
just
could have
wanna
been the
get that
sheriff. It was
in.
Gwinnett. It could have been the police. It could have been the sheriff. I believe it was the sheriff, but that initial transport is not a seamless, it's not a seamless process. And as a result, that is why I don't 1013 people in the field. That's why they go to the ER, because we don't have transportation for the initial transport. And I cannot handle somebody who's 260 pounds and homicidal by myself.
Well, again, part of this bill right here would help because it would allow police officers, without the penal offense, without putting somebody in the criminal justice system, to get access to mental health. I certainly appreciate it. Thank you.
All right, next person that would like to speak. If you just show me your hand, or want everybody to be able to put input. Am I missing anybody? Okay, I don't see any hands. Do you have, has any of the other members of the committee come up with any other questions that you have? Anybody online? Okay, I'm not getting anything. So I will declare this meeting adjourned. Thank you very much for everybody that came, for your input, and for my committee members for attending. I can ask you two.